Obsessive-compulsive disorder. History. From the 14th to the 16th century in Europe, it was believed that people who experienced blasphemous, sexual, or other obsessive thoughts were possessed by the devil. Patients suffering from obsessive-compulsive disorder, OCD, in these times were often treated via exorcism. Until the 1850s, obsessive-compulsive phenomenon was considered to be a variation of insanity. By the late 1880s, OCD achieved full clinical recognition. In early 1910, Sigmund Freud attributed obsessive-compulsive disorder to unconscious conflicts that manifested as symptoms. Freud details that patients with OCD develop the disorder starting in early childhood, when the person has a strong obsessive desire to touch an item. As time progressed, treatment for OCD shifted from focusing on the symptoms to treatment of the unconscious conflicts that caused the symptoms. This type of treatment was controversial as it did little to improve the lives of patients. Etiology. OCD can be broken down into biological and environmental causes. For biological causes, OCD has been linked to abnormalities with the neurotransmitter serotonin, although it could be either a cause or an effect of these abnormalities. Serotonin is thought to have had a role in regulating anxiety. Environmental causes can be broken down to traumatic events and stress. There are several reports in which OCD has been triggered by a specific, often traumatic event, including the death of a loved one, a divorce in the family, a move to a new location, usually involving a change in schools, or unhappiness at school. Additionally, cognitive models of the causes of OCD support the idea that stress increases intrusive thoughts, which also increases the risk of obsessions. Diagnosis. The American Psychiatric Association defines OCD as the presence of obsessions, compulsions, or both. Obsessions are defined by recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and cause marked anxiety and distress, or the person's attempts to suppress or ignore such thoughts, impulses, or images, or to neutralize them with some other thought or action. Compulsions are defined by repetitive behaviors or mental acts in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing distress or preventing some dreaded event or situation. However, these behaviors or mental acts either are not connected in a way that could realistically neutralize or prevent whatever they are meant to address, or they are clearly excessive. Treatment. There are many manners to address treatment, but two main treatments are cognitive behavior treatment and medication. Cognitive behavior treatment works the best when treated with medication. One specific method is the exposure and response prevention. Therapists expose distress stimulus to the patient and help them through the process. Medication involves serotonin reuptake inhibitors, which block the reabsorption of serotonin in the brain and controls the amount of serotonin, which helps the brain cells to communicate with each other. Also, serotonin reuptake inhibitors have less side effects than other antidepressants. They don't develop dependency and don't have withdrawal effects. Epidemiology. This is data from the National Comorbidity Survey Replication, nationally representing survey of U.S. adults. Lifetime and 12-month prevalence estimates for DSM-IV OCD are 2.3% and 1.2%. 28.2% of respondents reported experiencing obsessions or compulsions at some time in their lives. The mean age of onset OCD is 19.5 years. Males make up the majority of very early onset OCD, with a quarter of males before age 10. Females have much more rapid accumulation after age 10, with the highest slope during adolescence. Very few after their early 30s for both male and female. Those who developed OCD spend a mean of 8.9 years of life with the disorder. For African Americans, only 60% of those with severe OCD are receiving some type of treatment. From those 60%, only 20% are receiving SSRI medication, which is the most effective for OCD. Out of 454 participants from OCD specialty clinics, only 2.8% were African American. Almost no published studies are focused on the diagnosis, assessment, or treatment of African Americans suffering from OCD. For Latinos suffering from OCD, 1.4% were treated in Mexico City, 1.2% in Chile, and 3.2% in Puerto Rico. One study demonstrated no significant difference in OCD prevalence rates between Caucasians and Latinos, while another found significant difference between Caucasians and Latinos. Latinos tend to sodomize psychological symptoms for anxiety and depression, which is a barrier to treatment and may lead to increased misdiagnosis and wrong treatment.